Okay, now that I talked about lupus, I'm going to talk about osteoarthritis, joint condition affecting cartilage with a strong association with aging. Risk factors of osteoarthritis. So, main risk factors are age, gender, genetics, biomechanical stressor or previous injury, and obesity. Yeah, if you're obese, you have more risk to develop OA. So age, when you're more than 40, gender, women have threefold increased risk. We suffer too much in this life. Genetics, because twin studies show a twofold higher correlation in identical twins, and biomechanical stressor, because occupation with repetitive forces and sport-specific joint damage can affect the risk, like a higher rate. Obesity, because there's an 8-fold increased risk of osteoarthritis. It's maybe seem weird that obesity is linked to osteoarthritis, but actually it's not, because when you're obese, you have more weight to carry on. So all the weight that you have to carry on, you have to understand that it's linked to your skeleton. So of course the bones and the cartilage is going to be affected by any weight loss or gain. That's how I try to understand it. Okay, so symptoms: pain, morning stiffness and crepitus, which means like joints crunching. Radiogram, we can see the loss of joint space, subchondral sclerosis, white lines showing hardened bones, osteophytes, excess of bony outgrowths, and subchondral cysts. I'll have to watch the radiogram again, radiograph, again, because I don't understand all of this. So, treatment, Nimra, you don't have time. Treatment. Non-pharmacological treatment are going to target the risk factors, so weight loss, education about it, self-management. Sometimes patient education help way more than anything else. Physiotherapy, pain relief, and pharmacological treatment, the most important part of the class. Topicals, so capsaicin, paracetamol, NSAIDs, COX-2, selective. Intra-articular steroids for short-term relief. And I think I read in my, I'm not sure if it's for osteoarthritis or osteoporosis, that you can also have surgery. Let me double check this before I tell you nonsense. So of course, with the NSAID and the COX-2, now we know, we are used to it. You prescribe also a proton pump inhibitor to protect your stomach from the drug, a PPI. And you do not offer glucosamine, chondroitin, hyaluronan injection. Yeah, surgical treatment of OA. Yeah, I got it. So it just consists that you replace the joint with a metallical joint. Primary indication for pain relief, and may be difficult for patient under 50 years old. And it doesn't last indefinitely, like it's for 10 to 20 years. And it's the last resort you want to use. You are not going to talk about this straight to the patient who's presenting OA. Okay, you can also wash out the joint in arthroscopy, it's called. New therapies for OA: tirzepatide, it's GLP-1 agonist for treatment of obesity, and semaglutide in obese patients still. So I think it's targeting glucose, GLP, glucose lipids pump. I'm trying to guess, guys, it's not for sure. And yeah, it has to be taken once weekly. Trials show that it effectively reduced pain scores of patients when compared to placebo. Nice. Okay, now osteoporosis. That's why I'm confusing them all the time, because our teacher had the brilliant idea to teach both of them in the same class, like in the same slides. Osteoporosis and osteoarthritis. How do you want me to not be confused? Okay, it's different, I know, but the more I'm going to learn about them, the more I'll be able to differentiate them. OP is a disease of the bone, so cartilage, bone, remember it's not the same thing, characterized by the imbalance between osteoclast, the bone resorption cells, and osteoblast, the bone formation cell activity. Imbalance of bone production and loss leads to fragile bones. Lifetime risk in individuals over 50 years, women 1/2 and men 1/4. Risk factors that are non-modifiable: age, female sex, Caucasian, Asian ethnicity, and family history of osteoporosis. The risk factors that are modifiable: low calcium, vitamin D intake, sedentary lifestyle, just move bro, smoking and alcohol consumption, low body weight or eating disorders. Secondary causes are largely linked to malabsorption, endocrine, inflammatory diseases, medication malabsorption. To diagnose OP, you have to do a DEXA scan. DEXA, if I remember well, it's just, what does DEXA mean? I don't like to not know when I'm not going to ChatGPT this, I'm just going to Google this. Think of the acronym. DEXA stands for bone density scanning. Yeah, but it's not the letter okay, I'll just stop. I'm going too far for nothing. Sorry. DEXA scan, just to scan the bone density to know what's going on with the density of our bones, if it's normal or not. If it's normal, it means that you have a T-score higher than -1. If you have osteoporosis, it's going to be inferior to -2.5, and if it's in between, like in between -1 and -2.5, you have osteopenia. Management: lifestyle, always non-pharmacological treatment first, so weight-bearing exercise, calcium intake, vitamin D, smoking cessation, alcohol reduction, and if patient is postmenopausal, HRT may be encouraged. But what is HRT, bro? Okay, HRT, postmenopausal. Hormone replacement therapy. Okay, nice. I asked to Google told it to me. So why do you use ChatGPT, guys? And drug, these ones are interesting. I think I already kind of know them. Biphosphonates, first line, because it prevents osteoblast detachment. It's taken orally, limited to 5 to 6 years due to risk of brittle bones. Teriparatide, PTH analog, parathyroid hormone analog, reserved for severe cases. Denosumab, which a rankle inhibitor, modulates and stops osteoblast, given subcutaneous every 3 to 6 months and must not be stopped abruptly. Romosozumab, sclerostin inhibitor, cardiovascular risk with this drug. To prevent from OP, you can give zoledronate, shown to increase lumbar spine bone marrow density in trials, halved the risk of fracture in women, and stopped bone loss and therefore stopped reduction of bone density. However, in men, given testosterone replacement could increase their risk of fracturing. OsTeoArthRitiS OsTeOpOrOsiS. Ciao! I think I got it.